This is a tutorial to assist with your interpretation of patient results with our dried urine test for comprehensive hormones when the patient is using vaginal hormones. So just as a very quick reminder, in urine we don't find hormones in their free form except for cortisol. So when we're looking at reproductive hormones, testosterone, estrogens, if this represents testosterone, the way you find it in urine might look like this, just schematically. So it's testosterone hooked to a water-soluble group so that it can find its way into urine. So if you have a urine sample, it's essentially loaded with the hormone with this group attached to it. Okay, then we're going to unattach that group and test it. But if you take a vaginal hormone and it adds hormone from the local area, right? Because the hormone's going where the sample's coming from. So if you add that in, that hasn't been in systemic circulation as a hormone. That's a false positive. That's a contamination. So we have the only method that exists where you can take this sample, we remove the free hormone in the process of our testing, and then we test testosterone or estradiol or estriol. So the method works much better for vaginal hormones than most urine testing. So then what we're doing is we're going to evaluate the estrogens and look at the levels. Now, keep in mind, if you're giving the hormone for a symptom solely in the vaginal area, vaginal atrophy, vaginal dryness, that sort of a thing, you don't necessarily need to get systemic increase in hormone levels. It depends on what you're going for. So what this test is going to show you is systemic levels of hormones. So if you look at this patient, keep in mind the premenopausal ranges are up in here and the postmenopausal range is that little purple band. This patient finds themselves in the postmenopausal range. If they're on vaginal hormones, that tells you those hormones have likely not increased systemic levels of hormones very much, if at all. So again, the local tissue is going to get a lot of hormone, but probably not systemic levels of hormone. So again, depends on what you're shooting for. So then you can also evaluate the metabolites. If we get levels like this, now you're looking, if you look at estradiol and estriol here, see, they're slightly above the postmenopausal range and creeping towards the premenopausal range, which means you have increased systemic levels of hormones. And at that point, you're probably more likely to start affecting systemic things like hot flashes and night sweats and those sorts of things. So again, it depends on what information you're looking for. If you get results that look like this, you've probably pushed pretty far, and now you've got a systemic increase in estrogens that's very significant. Sometimes you'll see results that look like this, where the metabolites are not elevated, but the parent hormones are. And we want to evaluate this carefully because what happens is if it's only, let's say the patient's taking E2 and E3. Okay, if E2 and E3 are high and nothing else is, then it's possible we still have some contamination there because our method removes about 98%. So if there's massive contamination, you can see that type of a pattern where we have to go back in and actually do the evaluation again and use even a more sophisticated method to get rid of that contamination. Now, in a case like this, the patient's not taking estrone. That's E1. And so since estrone is high also, then that legitimizes these elevations because you can't contaminate with something you're not taking. So here you've got a high degree of the estrogens, but not as high a degree of the metabolites. And so you want to evaluate all of that as you look at the profile. And then as we look at the metabolites, we want to look at the relative distribution, and that's one primary use for urine testing is that the 2-hydroxy estrogens are considered more favorable, and you'd like to avoid a dominance by these two so-called bad estrogen metabolites. So we look at what it looks like in a typical person, which is about a 70 to 10 to 20 distribution. And here we're pretty close to 70, so the 2's about right. The 4's a little low, which is great, and the 16's just slightly high. So you would say that's pretty decent phase 1 metabolism. As those 2-hydroxy numbers start to drop, then that's something that we want to really look at and potentially address. And if the 4-hydroxy estrogens are predominating, then especially we want to make sure that methylation is working really well. The way you evaluate methylation, and this will be the last part of this, so if you're familiar with that, you can move along. But the way we look at that is to look at the 2-hydroxyestrogens and look at how much is converted to the methylated product. So both of these are about the same for the 2-hydroxy, but the methylated products are very different. So this one is much higher relative to the 2-hydroxy. So both of the hormones are relatively low here, but in terms of the conversion rate, the top one is high and the bottom one is low as we're evaluating the ratio between the two. So in the bottom one, you might want to be looking at potential genetic defects in MTHFR, or some of these things that that actually impact the methylation, or potentially nutrient deficiencies for things that are specifically involved in methylation. But methylation is protective for estrogens, but it's also important for DNA, for catecholamine, so it's a pretty important thing. So we want to always be evaluating that independently and also in conjunction with the rest of the estrogen profile. Now, when you're looking at routes of administration like perianal, so the anal mucosa is not as common as vaginal mucosa, but it's fairly analogous in that it's very different than transdermal or on the skin application. You're going to get a pretty decent uptake of hormones usually, and this test can help you evaluate that fairly well. The only difference with that is A, there's never a contamination issue with that, and then B, the anal area empties more directly into the liver, whereas the vaginal area doesn't. So there is some distinction there, and that's why we tell patients, if you're taking vaginal hormones, continue taking them. We will evaluate them. We take care of the contamination potential, and we can give you results that are both meaningful in terms of the amount of estrogen you're using, as well as the metabolism of the estrogen. And you want to evaluate that all together, of course, with the patient's symptoms and supplementation regimen as well.